I'm thrilled to be joined today by two leaders of the University of Alabama at Birmingham School of Medicine to get a sense as to what's happening both in the city of Birmingham, but more broadly in the state of Alabama. Anupam Agarwal is the chief of the Division of Nephrology and also the ASN President. And Jeanne Marrazzo is the chief of the Division of Infectious Diseases, and she's also a member of the board of directors of the Infectious Diseases Society of America. So Jeanne, Anupam, thank you for joining us for today's discussion.
Thanks for having me.
Thank you for having me, Todd.
So Jeanne, I thought I would start with you. I'm curious in terms of your role at UAB, what were the first steps you took as it became clear that we both were in the middle of a COVID-19 pandemic, but also that this was such a crisis situation?
Yeah, Todd, it's a great question. In some ways, it's been such a blur. It's almost hard to put a chronology on it. I think that those of us who lived through the SARS scare and then knew that MERS, Middle Eastern Respiratory Syndrome, was still smoldering in the background for several years now with a very high mortality rate. People don't appreciate that it's 30% still. When we heard about this in Wuhan, which was really early January, I think everybody was a little bit nervous. And I was actually at a meeting at NIH of the newly funded vaccine treatment and evaluation units in January, and Dr. Fauci did a kind of a welcome, and he was talking about it, and he used the term, we don't know what's going to happen, but he said, but this is scary business. And I think anybody who understands these viruses out of particularly China with this background of mammalian source that then jumps to humans, had to be anxious from the beginning. And so I would say in February, we here started doing some local media as soon as there was a hint that there might be cases exported outside of China. And you may, remember that happened quite early, as soon as Seattle. So I think, interestingly enough, the first steps that we did were not so much scientific as communication, and trying to lay the groundwork for people to understand that they needed to pay attention to what was coming down the pike. The second thing we did was to try to raise the alert level for the hospital system and the school, because I would say many people were not perceiving this, and this is no fault of their own at all. It's just not the world we live in. In ID, we've been living with this sort of like pandemic. We've actually been preparing pandemic plans for influenza now for several years. It's just not the world that they live in. And so we tried, I would say pretty early, to really mobilize the attention of our dean and our senior leadership and our hospital leadership to say, we need to be ready to mobilize the emergency response team, the infectious disease emergency response team. Let's think about the flow of our patients through the ERs, and let's think about what the infection prevention implications are. I have to say, I don't think anybody originally thought we would ever get to the point where we would be closing the hospital and having no widespread quarantine. But so the early things were more about communication and real sort of like, hey, this is not a drill, preparedness at the hospital level.
So Anupam, I'm curious, how did you first get involved in this conversation?
So we were hearing about this disease outbreak in China. One of my research technicians actually went back to China for Chinese New Year and got a call from her as soon as she landed there, actually sent us an email that there is this outbreak and I'm not sure if I'll be able to return in time. And her husband lives in Birmingham. So we were very worried and, looked up what this was happening. This was January 21st when this was really peaking in Wuhan. She's not from Wuhan, but from another region close to Beijing. And she's still stuck there in China. And now she has a date of May 22nd for a return, if everything goes well. So that was the first I learned. And then Dean asked Jeanne to serve on a task force for our UA system to start beginning planning that in case this, became really big in the United States, we needed to plan given the huge vulnerable population we have in the southeastern United States, in Alabama in particular, with the high incidence of obesity, kidney disease, diabetes, and cardiovascular disease, that we needed to be prepared if this were to, come. So I was part of the task force, and we still meet, regularly. Jeanne co-chairs that task force. So that's how I got, involved and heard about it in late January.
So Jeanne, Anupam mentioned the task force, and it's across the University of Alabama. I'm just curious as to what you're seeing in terms of the urban centers versus the rural parts of the state. I think we've heard a lot at the national media level about the urban centers, New York City, New Orleans, et cetera, but we haven't heard as much about kind of rural America and what's happening there with the virus.
Yeah. So one of the things that's so interesting about this process is people are learning about the sort of extent of powers that public health and local jurisdictions have relative to the state. And that's, I think, going to turn out to be a whole interesting area to investigate when we look back and see who instituted what and how people fared in their efforts to flatten the curve. So, for example, early on, the University of Alabama System Task Force that Anupam alluded to, that I chaired with the System Council and head of risk and compliance for the system, we were thinking about it not just from the standpoint of Birmingham and the campus here in Birmingham, which is the medical campus, and also the undergraduate campus at UAB, but also in Tuscaloosa, because of course the main University of Alabama undergrad campus and many other programs are there, as is the very large sports program. So we were sort of faced with discussing a situation that I hadn't really experienced before, which is that we had a very involved health department in Birmingham that we were in regular contact with, and who worked really closely with us at UAB. And that health department, in concert with the mayor, can actually exert significant public restrictions on things that turned out to be physical and social distancing and some of the measures that have been in place since then. However, we were also talking with the mayor of Tuscaloosa, who, despite his best intentions and really actually very, very sophisticated understanding of the epidemic and what was coming down the road, didn't have any power to exert this kind of health-related order. So this is where we realized that it wasn't just important to, talk about the school system and the related physical jurisdictions, but we also needed to have a voice and a presence at the level of the governor. And the governor, to her credit, convened a task force very early on, actually, that included me as well as the Mark Wilson, who is the public health officer for Jefferson County, and it was run by our state health officer. So it was very helpful because we were able to bring our perspective coming from this place, which was pretty much moving early on. I mean, I think we can talk about where we're at, and I don't want to jinx us, but right now we are well below the curve. We have really been blessed so far with our numbers of cases at UAB Hospital. We're seeing on average about maybe 2 to 3 new patients a day, which is a trickle compared to what we feared and well within our ability to manage it. And, we think it was because we did very early institute some pretty aggressive measures. Other parts of Alabama did not, and you could hear on the governor's task force that there was a wide diversity of opinion. Not surprising, we've seen it play out in many states where some people were completely uninterested in doing that. And if you look at what's happening now in Alabama, you've got a natural experiment that you could go back and chart the progress of the epidemic with reference to when things were instituted and how well they were adhered to. So it was fascinating because the local control over what you can do is not widely known, but turns out to be a critically important lever in how things evolve.
So I'm struck just listening as you tell that story that you had mentioned earlier that you had developed a pandemic plan. What seemed to have happened here was that it was very much from the local level to the state, and ultimately from the state, or ideally from the state to the federal. I would assume that your pandemic plan is the opposite, that you're thinking more from the sort of federal to the state to the local. Is that a correct assumption?
I think every state had their own pandemic plans for influenza. So this is not something I personally did, but working with a lot of people in public health and knowing the infectious disease folks who ran the public health departments. And when I was in Washington State in particular, before I came here, the pandemic flu plans were very guided by the CDC. So, and this is something that we may want to get into because CDC's virtual absence, I think, from the discussions here is been something that many people have really struggled with because CDC has always been the leader in thinking about coordinating state level, and some local health jurisdictions have kind of state level designation, like New York City, Seattle County, Atlanta. They are almost treated like their own little fiefdoms apart from the state. So CDC was always very, very involved in helping states develop their own pandemic plans, and the plans were pretty specific. They certainly reflected the best federal guidance because that's what you wanted them to do, but they were also very specific about who was going to do what in terms of the command center or the command structure, because it's all about, an emergency and who's in charge of ensuring that the schools are handled, who's in charge of ensuring that the stockpile has whatever vaccines you're hopefully going to get in there or whatever drugs you think you might be able to get to control things. So that all of those kind of eventualities were thought about very carefully. What wasn't, so I would say it was very much a public health thing, and kind of, academics was kind of involved, but not really. I mean, this was always really about how the information and the supplies and the directives and the guidance would flow from the feds to state and local health departments and then radiate out from there to the community. And that includes the academic community. What you ended up having here is a little bit of a double jeopardy, if not triple jeopardy, because the plans that we had were for flu, which are kind of relevant, but not totally, because this was a completely different virus. We're light years behind in terms of the vaccine compared to where we might be with flu, and certainly even with looking at antivirals. So that was one challenge. Nobody had a plan for things shutting down like this for 2 months. I mean, that just the economic devastation piece. I don't think anybody foresaw that, or the closure of healthcare systems, for routine care. And then the second double jeopardy part is that you don't have guidance from the CDC. So normally in a situation like this, I'm just thinking back to, big outbreaks we have had when we had the bad flu year several years ago. We've had a couple of them, but there have been a couple of really ringer ones. You would get guidance from CDC pretty regularly. CDC would have calls where clinicians could get on. You could learn the latest. There would be lots of updates, and we just really haven't seen this during this pandemic. So that's part of the reason that the local responses have been so diverse, so lame in some places, and because health departments are not well resourced in some places, and also so incredibly strong in some others that have great health departments. I often say thank goodness that Seattle was the first place to experience this outbreak, because in terms of having an infrastructure where you have a really strong marriage of public health, academics, and industry, especially laboratories, science-based industry, and information technology, you could not have had a better place to have this happen, because, and that's the only reason they were able to get it under control so early and not experience what New York ultimately experienced.
Anupam, I know one of the issues that you've been dealing with is, as we think about the variability across states, is how individual states consider patients and patient populations and what I'll call sort of rationing of care, or at least prioritizing care. I'm curious as to your experience around the ability in Alabama for people with kidney failure to have access to ventilators.
So thank you, Todd, for that question. So we were alerted a few weeks ago about a old state of Alabama guideline from 2010 that multiple conditions underlying would exclude you from getting a ventilator if there was a shortage, and that included kidney failure, both acute and chronic. If you were on dialysis, you would be excluded. One of my faculty members brought it to my attention, so I brought it to Jeanne's attention right away, and she took it up with the task force for the state, and they said they would really default to our UAB's guidelines that was actually being developed. And in that guideline, because of Jeanne's efforts, they ended up removing any of those chronic conditions that would exclude you from requiring ventilators. There was a JAMA paper on this topic as well. And then with the efforts of the ASN and the National Kidney Foundation, writing a letter to the National Governors Association as well as the Office of Civil Rights, that resulted in a letter from the Office of Civil Rights to at least two states, Pennsylvania and Alabama, and they took those guidelines out and have updated them. So that is no longer an issue. But clearly, this is a very state-specific issue. So, it's ethically wrong to have patients being denied a ventilator just because they have, a chronic condition. For example, if they need dialysis or, for acute or chronic kidney disease. So it took, I think the community also was quite vocal. I was contacted by a practice in town, and they were, getting a letter signed by all the nephrologists in Alabama to the Alabama Department of Public Health, protesting against those guidelines that were outdated from 2010. So I think clearly that's a place where I could see societies like Infectious Disease Society or ASN, could really play a key role in shaping, policy and guidelines that may have been wrong and for whatever purpose, but they need to be revised and updated. And I think that was, a great example of how we were able to accomplish that.
So, Jeanne, I won't hold you to this, but I'm curious if you were to predict the course of COVID-19 over the next, say, 3 months, then 6 months, 9, 12, 18, somewhere in there, what's your best guess?
Yeah, that's the $1 trillion question. My best guess is there's so many variables, but let's just say that things continue as they are. So if you look at the Northeast and the urban centers there, you're probably seeing the plateau. The deaths are coming down. The deaths are generally about 2 weeks behind the peak number of cases. So, I think that in areas where there was a sort of a saturation with an appropriate social physical distancing response, you're going to see this waning down. In areas that have outbreaks that have not been so well controlled, and we're seeing this certainly nursing homes. We're seeing it in meat and poultry processing plants. Northern Alabama is having an issue right now, poultry processing. The Midwest, Nebraska, really bad. Kansas, bad meat packing sort of plant activities. So where, if you don't sort of see those kinds of outbreaks spread, and the rest of us, like Alabama, for example, continues to do some degree of social physical distancing, which we just heard today they will, which is pretty remarkable, and we can come back to that if you like. It's going to, I think, be a series of variable epidemics that are going to be very much dependent on the balance between what their disease burden is to start with and what they've been able to do to mitigate the spread. So in Alabama, if we can get Mobile under control, and we can get a couple of our other communities on the eastern border under control, meaning that, we hit a plateau and we aren't going any farther, I think we'll probably reach some sort of steady state. And if we continue to do social distancing, we could probably continue to drive down the R naught less than 1. And that's really what we want to do. So remember, R naught is the reproductive rate of any infection. If it's less than 1, it means, if it's 1, it means on average, every person who's infected infects one other person. If it's 3, it means you infect 3 people. If it's like measles, it's like 14 people, because measles is so incredibly infectious. So we've had a lot of discussion about what we think R naught is for this virus. And it obviously depends on, what stage of the illness you're in and how intensively you're shedding. But on average, people think it's probably between 2.5, around 2.5 to 3. So if we could get to a place in either isolated pockets or in larger parts of communities where there is not such population density, you might be able to get to that. And I think if you do, so that gets to this issue of it's a complex interplay between population density and the ability of people, or likelihood that people are going to come into contact, versus what the underlying rate of infection is in that community. So think of an apartment building in New York, or a community gym in New York, or something like that. It doesn't take very many infected people in a setting where you're sitting, 6 inches away from somebody, or a subway car, for those infections to really continue to propagate. If you're talking about a rural community in the middle of Georgia or Alabama, that's going to be very different. You can have a handful of infections and they're probably going to die out. So there's kind of 2 variables there. It's not just the infectiousness of the virus as a particle, but it's really this dynamic of human interactions, and that's so related to how we assemble in public places and in our work settings. So my best guess is that we will continue to see sort of this simmering low level, and everybody's going to get to some sort of steady state, whether it's not a great steady state, or whether it's going to be an acceptable steady state, which is kind of where we are here right now. And then almost certainly there are going to be these eruptions of outbreaks, and the eruptions are going to come because people are really ignoring the practices that we're trying to get them to do as we reopen society, right? So, you're going to try to reopen society gradually, as we're doing now here, but you still want people to exercise personal hygiene measures. You would like them to do some degree of physical distancing. And in Birmingham, as of May 1st, we have to wear masks in public, which is very interesting and very un-Alabama. So if you can do that, then I think you can kind of keep it at a low enough level that you can then detect those blips, right? That are, I'm sure, going to occur in, I really worry about long-term care facilities. I worry about correctional facilities, like everybody really does. And then once you see those blips, then ideally, if your background rate is low enough and you're prepared, you've got the resources to go in there and do contact tracing. You get the infected people cohorted, and you can isolate in a small enough group that you can actually make a difference. So that would be my best case scenario. I think the degree to which and the pace at which people and individual communities get to that point depends exactly on where they are right now. So do I think that rural Mississippi, rural Arkansas are going to be there in 2 months? I worry about that a lot. I don't even know if Mobile will be there. I think Birmingham could be there, depending on how things go. So, sorry, complicated answer, but there is no one right answer. And I think it's going to be, and that's kind of why these models that have been state specific have made us crazy a little bit. And Anupam can comment on this. I mean, there was a period there where the Seattle IHME model was out saying that we were going to need like 1 billion ventilators in Alabama, and the media was going nuts, and we were getting calls and please tell us what are you going to do? Are we all going to die? And, you can't model a whole state when you've got the complexities that we're dealing with here. And I think that's true pretty much for everywhere. So hence, sorry, long answer, but I think it's really important to think through all those details.
Yeah, to take up on that point, Tod, Atul Gawande tweeted out, "What the hell is happening in Alabama?" And put out the projections from IHME, but they're completely not taken into fact that we had already started social distancing. We had stayed, and actually the next day, April 3rd, our governor announced stay at home, and they had to revise their projections. And clearly, that was completely a different story. So,
yeah.
So I have to ask selfishly, since you mentioned it. So when we do go back into the office, I take the subway every day, about 20 minutes on the train in and 20 minutes home. How do I protect myself?
Yeah, I think a couple of things. I think that masks are going to be really important in those situations. And you could ask what kind of mask. In the subway, I would wear the best mask I could get. We've been saying that when people wear masks to go to the grocery store, they're generally wearing them to protect other people from their own body. So whatever you're breathing, whatever you're coughing, you're wearing a mask so it doesn't get out into the air around you. The subway is a little bit of a different story, right? Because you don't really have the luxury of making sure everybody else has a mask on, although they should. And personally, if I had an N95, that's probably where I would wear it. Should everybody on the subway be wearing an N95? No, because we want to make sure that healthcare workers have access to them in the hospital. And we've been very clear about that people in general should not be walking around wearing N95 masks. But, the subway in a city that's had a substantial outbreak, to me, is different than walking into the Piggly Wiggly in Birmingham, Alabama. Very different. Going to the Piggly Wiggly, which is our grocery store, I would be perfectly comfortable wearing a bandana mask or a cotton mask. I would usually like to wear a blue cone mask or a surgical mask, but I think that's probably overkill. So I would be very attentive to that. I would have hand sanitizer. I would definitely, if you touch surfaces, then make sure you're really crazy obsessive about washing your hands and not touching your face. And I think you'll be okay. I mean, the reassuring component of that for you to help you sleep better at night is that since masks have been instituted at healthcare facilities, UAB, Seattle system, the whole Seattle system. This is really interesting. They have had, and we have had no healthcare employee infections. So I think that the masks really, really work. And if you're really attentive to hand hygiene, I think you're 95% there.
I'll also add, Todd, that initially during the pandemic, at least our institution, we had several of our healthcare workers getting positive just because they were getting exposed to, asymptomatic individuals. And a lot of these were in the community. But as soon as we went to universal masking in our whole hospital, I think for a few weeks now, we've not had a single healthcare worker test positive.
Well, I apologize for going long, but I'd like to ask you each the same question just to close. In Anupam, I'll start with you. In your role as ASN President, I'm just curious as to what you've been most proud of that ASN has done to try to help during this crisis.
I think several things. ASN Policy and Advocacy Committee, the Quality Committee, and several others have worked really hard in making really sweeping changes, that have occurred very quickly through CMS, particularly with the telehealth coverage for our dialysis patients. Over 500,000 in the U.S. We have to see them 4 times a month to, bill for their monthly capitated payments. But now we can do that by telephone or televideo visits, which is a huge, for us to not abandon our patients, but be able to continue providing care and making sure they get, the best possible dialysis. I think that was huge effort by our society in terms of working with CMS and moving that forward. So I think that telemedicine coverage is probably, number one on my list.
And Jeanne, in your role as a leader with the Infectious Diseases Society of America, I'm curious as to what you've been most proud of that IDSA has done during this crisis.
I think a couple of things, but the biggest one is probably their getting together and issuing treatment guidelines about 2 weeks ago now. And there's a political background to it because there since that time, there has been also guidelines issued from HHS, from NIH, which is great. But the discussion of who was going to come out and say that we have no effective therapy for this infection, we have no evidence that certain drugs that have been overtly politicized work and in fact can be harmful, which everybody is comfortable saying right now, that actually was a pretty hot potato for a while, unfortunately. And in fact, it may have, I don't know this, but I would not be surprised if it contributed to a delay in the guidelines getting out from the NIH. But regardless, IDSA sort of stepped up to the plate and said, there's no way that we're not going to address the needs of not just our society members, but clinicians at large, and say that, and put out guidance that we really can stand behind, and that we think is scientifically credible and will evolve, importantly, over time, because of course the data is never sitting still. So I think that was a really important message, and it's a message that I think we still need to continue to hammer home, because we're still hearing there's just a lot of misinformation out there about how to treat this infection. And as you know, when you have something that is killing people and you feel like you're standing by and you're not doing anything, it's hard to even discuss with people why you're doing randomized controlled trials, because they just don't necessarily want to participate in those. So I think the fact that people were willing to take stand and put themselves out there in the face of what had become a lot of unfortunate discussion was very, very good, and I think will continue.
Well, Jeanne and Anupam, thank you very much for taking the time to talk, but also everything you're doing at a local level, at a state level, and a national level during this pandemic.
This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition, or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.